Hello, welcome everyone. As people are getting in, I'll start welcoming everybody. I'm thrilled to see so many of you joining us from all around the world for this crucial conversation about protecting some of our most vulnerable patients, newborns, and children. On behalf of IAPO, welcome to Engaging Families and Communities, Protecting Every Newborn and Every Child. Quick housekeeping, you can enable captions in your preferred language by clicking CC at the bottom of your screen, and Zoom will automatically translate the captions for you. If you experience any difficulties with this, please don't hesitate to reach out to us in the chat, and someone from the IAPO team will assist you. Would love to get to know you. Please take a moment to introduce yourself in the chat. Also feel free to use the chat or the Q&A box to share any questions for our speakers. We'll address as many as possible during the Q&A session. My name is Antonia Gama. I lead policy at IAPO, the International Alliance of Patients Organizations. For 25 years, IAPO has been supporting and mobilizing almost 300 patient organizations across all disease areas and all regions of the world, empowering them to play an active role in shaping the global health landscape. We're co-hosting today's webinar with the Patients for Patient Safety Observatory, which Dr. Neda will tell you more about shortly. Now, let me introduce you to our valued moderators. Dr. Neda Milevska-Kostova is the president of Patients for Patient Safety Observatory and chair of the AMR Patient Alliance. Neda is a caregiver and a patient advocate. She holds a PhD in public health and has extensive experience in health policy, patient engagement, and influence of global and regional agendas on national health policies. In 2018, she was awarded a Premier's title by the Minister of Health of Macedonia for exceptional achievements in promotion of health and development of healthcare systems. Currently, she's a postdoctoral researcher in the Netherlands and a consultant on national health policies for the World Health Organization. And Dr. Aida Taha is a technical officer at the Patient Safety and Quality of Care Unit at the WHO headquarters, a medical doctor and public health specialist. She leads several global health initiatives, including the World Patient Safety Day campaign, the Patients for Patient Safety program, and the Global Patient Safety Network. She also led the development of the WHO Patient Safety Rights Charter, which aims to empower patients across all healthcare settings, and was a key contributor to the Global Patient Safety Action Plan 2021-2030. Neda, over to you.
Thank you, Antonia. Good morning, good afternoon, and good evening, everyone. I can see a participant number rising, and it is a great privilege to be able to welcome you. I hope you can introduce, like Antonia mentioned, please introduce in the chat. So by that means we can also know who you are. Today is really great privilege for me to be back in the loop of the webinars and experience and knowledge sharing with IAPO. Thank you, Antonia. Thank you, Dani, the entire team of IAPO for inviting me. Thank you for Aida to agreeing to co-host, and to all the speakers. Thank you as well for agreeing to share your valuable thoughts, experience, and ideas of how we can improve the safety. This year's World Patient Safety Day is about the neonatal and children safety, or child safety. It is really critical to start safe and with high quality from the beginning, from the start. What we are, as societies, hoping is that the future generations will grow to be healthy, to be productive, so that they can really breathe the further generations and improve the quality of life for everyone. But if we don't start, with a good quality of life and safe start for a newborn, this will likely to drag along. Evidence shows the topic of this World Patient Safety Day was chosen because the evidence shows that the adverse events are alarmingly high, especially in low and middle income countries, but in the high income countries alike. So we need to unite our voice to see, to gather the evidence from all across and make sure that we prevent what is preventable or make sure we improve the harm where it was done already, at least to provide for a decent, high quality of life from the start of life and throughout the entire life cycle. With this said, and as Antonia mentioned, the IAPO the Patient for Patient Safety Observatory is co-hosting with IAPO this webinar, and we are also grateful for that. I'm the president of the observatory, and this was set up as an organization in Geneva 5 years ago, together with IAPO and the World Health Organization Patient Safety Flagship Initiative, as an idea to try to make a common space where patients will share their voices, their experiences, and in a scientifically rigorous way, we try to capture the patient voice to make it part of not only research, but policy, everyday practice, and our lives as such. So this is what the observatory is trying to capture and working on. But without the enabling environment that WHO has created by the Global Patient Safety Action Plan and organizing these World Patient Safety Days, I don't think that it will be possible for our voice to be articulated and to be heard by the governments. So with this, I would like to transfer the floor to Ida, my co-moderator. Please welcome, the floor is yours.
Thank you so much, Nada, and also allow me to extend a warm welcome to everyone who's joining us from around the world today. Every year on 17th September, the world comes together to mark World Patient Safety Day. This day was established in 2019 to raise awareness on patient safety, to engage stakeholders, and to mobilize action to reduce or eliminate avoidable harm in healthcare. This year is no different. It's a very special year because we are speaking about the most special to our hearts, who are our children. And with the theme Safe Care for Every Newborn, Every Child, we're trying to highlight that patient safety in pediatric care has to come first and in every healthcare setting. So one of the main issues that the campaign aims to highlight is why children are more at risk of harm, as Neda mentioned. And that is because of their rapid growth and development, their ever-changing health needs, their reliance on others and adults to take care of them. And because they have a different disease epidemiology than that of adults. So at different stages of life, they contract different types of diseases which present differently, and the treatment of which also poses different risks. Not only that, but children who come from disadvantaged backgrounds were also found to be more at risk of harm, which is something that we really need to think about when developing interventions. So the campaign has 4 clear messages, which is that children should not be treated as small adults. They really need care that is tailored to their age, to their weight, stage of development, their ability to communicate, and also the context that they come from. The most common causes of harm are known, which is good news. That means that we can focus or zoom in on our interventions. Those include medication errors, errors related to diagnosis and failure to recognize early deterioration, healthcare-associated infections and issues that are related to medical device use and surgical-related errors as well. So, in a nutshell, in order for us to improve the bigger picture we definitely have to have safe systems or well-designed systems, a supported staff, which goes beyond training. And we also need to have teamwork with families and caregivers being seen as essential partners and members of the healthcare team. So every voice counts at the end. To help turn these messages into practical action, WHO has launched a set of goals to be implemented at facility level, which address the major causes of harm. And these are engaging patients, children, and families, enhancing medication safety, improving diagnostic safety, preventing healthcare-associated infections, and reducing the risk for small and sick newborns. The goals are grounded in existing WHO guidance and are aligned with the Global Patient Safety Action Plan with global strategies such as Sustainable Development Goals. It is also is aligned very much with the WHO quality standards for children and newborns. So the goals provide practical actions for healthcare facility managers and health workers to embed safety at the point of care where it matters the most. So with this framing in mind, we're now ready to hear from our speakers who will bring practical strategies and their lived experiences to life. I hand over to Neda again to introduce our first speaker. Over to you, Neda.
Thank you, Aidan. Thank you for laying out in a very both strategic but also practical terms what the goals are of this World Patient Safety Day, what is the focus, and how we as individuals, but also as advocates and as a system can help to improve the situation. It is my exceptional honor to have Dr. Neelam Dhingra today, and I hope it is for the over 100 attendants who are at the back listening as well. Thank you so much, Neelam. I know these days are busy because you are always invited to present on patient safety, but also presenting and sharing your experience globally. Many people would like to have you, so we are very delighted and happy to have you. To the audience, I don't really think Dr. Neelam needs a special introduction or presentation, but I will anyway give it a due presentation. So Dr. Neelam Dhingra is currently a Vice President and Global Chief Patient Safety Officer for the Joint Commission International that she joined after 25 years at the WHO, where she actually not only conceived, conceptualized, drilled across different levels, made alliances with different departments to finally have the World Patient Safety Action Plan in place, adopted, and now rolling, and also setting up this World Patient Safety Day to commemorate those that have been harmed, but also to learn from their mistakes and improve the care. At the Joint Commission International, she continued her work from the WHO shoes, and there she set up a whole different level, and that is really to practically implement what was in the action plan, and that is trying to build pathways for those who cannot keep up with the high resource environments, for those in low resource settings, to be able to have as high as possible quality and safety of care as in the other, because everyone deserves to have the highest quality of attainable care. Also, Dr. Neelam has a lifetime membership of ISQA, which is again quality related to the quality and safety of care, then affiliate faculty, not to mention all, but just to mention Johns Hopkins Bloomberg School of Public Health, the Singh Duke NUS Institute of Patient Safety, and so on and so forth. And that's only to mention a few. So it is to illustrate how happy we are to have you, Dr. Neelam. Thank you again for accepting to be with us. We know the days are really busy for you, but we would like to really hear from you about the strategy for improving pediatric and neonatal safety in the sense of infection prevention, medication safety, and system improvements. Please, the floor is yours.
Thank you so much, Neda, and thanks, Saida, and thanks, colleagues, for giving me this opportunity to connect with you today. Hello and greetings from the Joint Commission International, and a very happy World Patient Safety Day 2025. First of all, I would like to congratulate the International Alliance of Patient Safety Patient Organizations, IAPO, for organizing this event to mark World Patient Safety Day. And thank you so much, Neda, for your very kind introduction. I would like to express my deep appreciation for Dani, Antonia, and Neda for their leadership and unwavering commitment to the cause of patient safety and elevating the voice of patients across the world. And it's unparalleled. The reach to patients around the world of IAPO is unparalleled. My greetings also to my WHO colleague, Ida, for co-moderating this session. I've been asked to speak on strategies for improving pediatric and newborn safety, focusing on 3 key domains: systems improvement, infection control, and medication safety approaches. And I actually have a couple of slides, and let me see if I can share those with you just to contextualize the issue. So let us see if you are able to see my slides. Right, great. So I think you can see my slides.
We can. It's working well, Dr. Neelan.
Right, great. So in the interest of time, I just want to say that the most important part of any health system for safety is systems improvement. And basically, safety improvements, the systems improvement for safety need to address 3 aspects, primarily: culture, processes, and data. And systems change is how these clinical interventions we have mentioned, infection control as well as medication safety, they really become reliable. So some of the foundational elements of leadership and safety culture are visible executive leadership and daily safety huddles, for example, to foster safety culture that reduces adverse events. Standardized handoffs and checklists, for example, utilizing structured handoffs like CBER and procedural checklists to ensure reliable clinical processes. Family engagement, and that's why we are here, to educate and engage families to enhance the safety and also detection of errors. Data for collecting metrics for driving improvement cycles, and simulation and staffing, for example, multidisciplinary drills to prepare teams for emergencies, and proper staffing and layout to improve patient care. So a recent article published on the occasion of World Patient Safety Day emphasizes that safety first always in every healthcare setting. So pediatric readiness is an important strategy to ensure that care settings have appropriate pediatric resources, such as medication, equipment, policies, and education, as well as trained staff to care for children. Special approaches to prevent newborn misidentification, particularly including specific naming systems for newborns, identification banding or barcoding, and also visual communication alerts for newborns with similar names. In ambulatory pediatric settings, safety can be improved with standardized prescribing, appropriate decision support tools, and communication strategies. And in the home setting, strategies include health literacy informed counseling strategies like teach back or show back, patient education materials, including pictograms also, and providing standardized dosing tools to accurately measure liquid medications, for example. The other important aspect this paper also elaborates is safer care depends on safe systems and teamwork. So an institutional culture of safety that supports reliable and flexible approach to reporting and shared learning from adverse events. And human factors approach, which can support safe systems and improve interactions between patients and families and healthcare providers and technology, as well as environment. So, and it's been seen that interventions which are based on and focused on safe systems and teamwork can actually improve pediatric safety significantly. Trigger tools can identify safety incidents and promote measurement and also reduction of adverse events. And similarly, handoff tools can also have been shown also to reduce medical errors and preventable adverse events and improve communication as well. So using structured communication in patients and family-centered rounds can significantly improve family and nurse engagement And engaging patients and families in safety surveillance has been shown to improve error detection by 16%. So let us look briefly at the infection control strategies. The core principles are to prevent infection transmission, protect invasive devices, as well as support host defenses like breastfeeding and immunization in neonates. So for hand hygiene, using alcohol-based hand rub at point of care with compliance audits and feedback to ensure effectiveness is a very important strategy. Similarly, standardized entry procedures enforce, for example, bare below the elbow, and also visitor screening, removal of outdoor garments, and control of footwear and linens have been also shown to reduce infection with standardized entry procedures. Device care bundles, for example, apply insertion checklist or maximal barriers or chlorhexidine preparations and review of devices necessary to daily reduce infections. And now looking at medication safety approaches, and it has been said that children are not small adults. So weight-bearing dosing and varied formulations and small margins can increase risk, and medication errors are among the and small margins actually increase the risk, and medication errors are among the most common sources of harm in children. Some of the high impact strategies which have been also elaborated are standardized concentrations and preparations. So using unit standard concentrations for neonatal infusions and also ready-to-use syringes have been shown to reduce calculation errors. And weight-based dosing and double checks, always document the weight, calculate milligrams and kg doses, and also require independent double checks for high-risk medications, for example. Smart pumps and barcode medication administration technology, particularly employ dose error reduction softwares, maintain infusion pumps libraries, and use, as I said, barcode medication administration technology at the bedside have also been used, seen to reduce medication errors. And also error reporting and decision support. So by implementing non-punitive error reporting, root cause analysis, and some of the safety science tools, and use electronic decision support with alerts and formularies also has been shown to reduce the risks. So finally, in the short presentation, I want to just give some key messages. Most importantly, comprehensive safety approach. Improving safety requires a thorough strategy involving prevention, system change, measurement, and implementation. Prevention focus is important. Focusing on prevention helps reduce risks and also protect children and newborns from harm in healthcare. And better outcomes, effective implementation of safety strategies, they lead to safer environments and also improve health outcomes for children. So finally, I would like to conclude by saying that investing in children is perhaps one of the most powerful and transformative action in society can take to build and secure a healthier and more equitable future. And World Patient Safety Day this year presents a very timely and powerful opportunity to accelerate these efforts, to galvanize political will, to elevate the voice of patients, and to drive measurable improvements in the safety and quality of newborns and children. So with that, I conclude my presentation, and I'll be happy to answer any questions.
Thank you, Dr. Neelam. And knowing that you have to leave sooner, maybe we can first ask you the questions and then we come back to the other speakers. Like you rightfully said, the pediatric readiness is really an important element. And of course, echoing also Ida's words that pediatric patients are not only small adults and cannot be considered little adults. Not only in clinical terms, but also in cognitive terms. It means that many times adult patients, if they notice an error, they can flag it, they can observe it, they can communicate, but this cannot be done by neonates or the children. Therefore, we need twice the attention, we need twice the systems to ensure that medication or medical errors are prevented. And the same goes for the infections. So in this sense, from your experience, from your vast experience, what would you say that would be some of the maybe key first steps or low-hanging fruits or some of the first elements that the healthcare system need to take, or in particular, the health providers or the hospitals can do to implement this system?
The great question, practical high impact first steps can really save lives in low resource settings. And also, they actually map very beautifully with the WHO Global Patient Safety Action Plan. So I think the most important is a strong visible leadership. To get a visible leadership which is supporting, and also create a small safety team. And at the facility, for example, ask the facility leadership to name a focal person and a small multidisciplinary safety team, which has pediatricians, clinical officers, pharmacists, midwives, nurses, and family representatives. And this will actually align also with WHO call for governance and culture and accountability. Then second, I think very simple steps are introduce one checklist or one bundle at bedside. Start with, for example, start with the WHO Safe Childbirth Checklist or an essential newborn care bundle. And use of the checklist at the 4 pulse points during delivery and labor, and ensure that every child has basic essential newborn care. Because checklists are low cost as well and have clear evidence of improving delivery of essential practices. Then I would say strengthen basic infection prevention and control. So prioritize hand hygiene stations, for example, either alcohol-based hand rub or soap and water at the point of care. Clean delivery kits and equipment, routine cleaning schedules, a single-use or well-disinfected equipment for neonates. And also sometimes, organizations have shown that when they track hand hygiene moments, and that actually addresses significantly improves the hand hygiene compliance. Even small IPC gains, I would say, they cut neonatal and pediatric infections. Then making pediatrics medications and dosing safer. So standardize and simplify. Implement waste-based dosing charts, pre-printed order templates, for example, and also a local high-risk medication list. Double-check rule, for example, for antibiotics and IV fluids. So use simple job aids like posters, pocket charts, so staff don't have to recall complex calculations, particularly during busy shifts. And these are, again, a high-value, low-cost safety win. And WHO Action Plan, particularly the Global Patient Safety Challenge on Medication Without Harm, emphasizes that we have to have special measures for reducing medication errors in neonates and children. And I would say engaging families and communities as partners are very, very critical, because families are critical safety partners for newborns and children. So teach mothers and caregivers, for example, basic danger signs of feeding, breathing, temperature, encourage skin to skin and rooming in, and also invite caregivers into bedside rounds as well, where safe. And finally, I think the other point I want to mention is about non-punitive incident reviews and small quality improvement cycles. So start monthly short morbidity mortality reviews, for example, or learning from errors that focus on system fixes, not blaming individuals. And also we can use simple PDSA cycles, plan, do, study, act, for one problem at a time, like reduce hypothermia after birth. And this builds a learning culture, which is recommended by all global organizations. So I think there are several simple first steps, which, out of these points which I mentioned, which facilities and healthcare leaders can introduce to gain even small gains, which will have major impact on reducing the risk of infections, the medication errors, and strengthen the systems for improving patient safety.
Thank you, Dr. Neelam. Maybe one very, very short, just to catch on something that is interesting to the audience for sure, and that is, you mentioned the patient and family engagement. So how would you see maybe a collaboration between IAPO and JCI in really addressing this other side of the patient safety medal?
I mean, this is absolutely impressive and great question, because there are huge opportunities for IAPO and Patients for Patient Safety communities and also JCI to work together. And I would say one of the key approaches and areas of collaboration could be knowledge sharing and harmonization of standards. JCI, for example, brings clinical quality and accreditation expertise and through Pathways also brings several strategies for lower middle income countries in the public sector hospitals. And IAPO and PFPS communities can bring patient and family perspective. And we can collaborate to create globally accessible guidance on pediatric safety, which is aligned with WHO patient safety priorities and also adaptable to local context. Then global to local networks also, I think, is very important. Like IAPO can connect international best practices with national patient organizations. And PFPS communities can ensure that family voices are integrated, especially on issues like medication safety for children, on neonatal infection prevention and control, and respectful care. And JCI can provide technical input to ensure these practices are evidence-based. Another area of collaboration could be capacity building and training. So joint training programs for healthcare workers, which include some clinical safety protocols from JCI and patient strategies for partnering with patients with IAPO and PFPS, and also clear stories from families to highlight risks unique to children and newborns can also be another area of collaboration between JCI, IAPO, and PFPS for pediatric safety. And I would say sharing of learning platforms. For example, creating an online repository, which PFPS already is, on pediatric safety case studies, toolkits, and culturally appropriate and sensitive communication resources. And also engaging cross-country learning exchanges where hospitals and patient advocates and policymakers discuss what works in low-resource and high-resource settings. And finally, I would say that policy advocacy together, present a unified voice to ministries of health and WHO to ensure pediatric and neonatal safety is prioritized in national health strategies, and use joint position statements, which are backed by clinical data, patient testimonies, and global advocacy reach through all the organizations. So I would say that these three organizations can combine the strengths, clinical rigor, patient partnership, and advocacy reach to spread best practices more effectively and make sure that both healthcare workers and families are equal partners in keeping newborns and children safe.
Thank you. Thank you, Dr. Neelam. Also on behalf of the other moderator on IAPO, but also of all the attendees, because there are many messages coming through in the chat. We can read some later on, but many people thank you also for this presentation. I just wanted to voice that. The key messages from what I got from your presentation is really standardize and simplify, then exchange knowledge, and also try to convert the global to local in sense of policies, but also bring the local examples to the global policy agendas so that they are introduced and they're embedded not only in the global plans, but also in the national action plans and in the hospital guidelines. So those would be some of the first steps to take, and how we can collaborate between IAPO and JCI. It will be really a pleasure to continue this offline. Thank you very much again, and I would like to transfer now to my co-moderator, Aida Taha. Please, the floor is yours to introduce the next speaker.
Thank you so much indeed. Thank you.
Thank you very much, Nada, and it's always a pleasure to see Dr. Neelam. Great to see you. So it gives me great pleasure to introduce Ida Ferdinandi, who is the lead of the Early Childhood Development Program in UNICEF Country Office in Montenegro. While working for UNICEF since 2009, she has supported the government of Montenegro in planning and implementing policies, programs, and reforms in the areas of deinstitutionalization, protection from violence, parenting support, maternal and child health and nutrition, and early childhood intervention. She holds a master's degree in social sciences from the University of Freiburg in Germany and the University of KwaZulu-Natal in South Africa. Ida will speak to us today about the unique vulnerabilities of newborns and children, improvement of quality of care, and clinical practices in Montenegro. Ida, the floor is yours.
Thank you so much. I hope that you can hear me well. And I'm going to share my slides now. And I will just kindly ask you, Ida, to confirm if you're able to see it in
Yes.
slideshow view. Perfect. Thank you so much. And I really enjoyed all the presentations so far, including by Dr. Nealon, because I think it really sort of resonates with what I'm going to present to you, which is a case study from Montenegro. I'm going to give you a little bit of context because Antonia told us at the beginning that there's people around the world joining this webinar. So Montenegro is an upper middle income country in Europe, which is on the EU accession path. And a lot of reforms in the country are driven by this EU reform agenda. And it has only 600,000 people. You can see here some of the health indicators, which I picked, for the purposes of this webinar. And you can see that Montenegro has very low neonatal mortality rate, low infant mortality rate, also rather low maternal mortality rate, which is sort of aligned with the EU average even. However, there are also some challenges. For example, you can see that the rate of cesarean section is quite high. It's 24% according to MIX, the UNICEF supported household survey, but we think that the rates are even higher now because according to administrative data, the percentage ranges from 30% in better performing facilities to even 60% in some facilities. Early initiation of breastfeeding was also very low in 2018, only 24%, and skin-to-skin care was only 34%. And we hope that these figures have gone up because we have really invested a lot of efforts in this area, and we will be able to see that next year, hopefully, because we are supporting the government of Montenegro to conduct another round of MIX this autumn. So I'm going to present to you the assessment of the quality of maternal neonatal services in Montenegro, because patient safety agenda is, in our case, embedded in the broader quality improvement agenda. And I will focus more on the newborn aspect in line with the topic of this webinar, because I know that Patient Safety Day was dedicated to maternal health a couple of years ago. So this assessment was conducted in 2023 by a team of 3 international and 16 national assessors who were capacitated to join the international team. All public health hospitals and 4 primary healthcare centers that provide emergency obstetric care were assessed, and you can find the report on our website. The tool that was used was a WHO tool that you can see here on the screen, which was updated by the international assessors and already piloted in other countries in Central Asia. And the data collection methods involve direct observation, document review, interviews with staff, interviews with patients, interaction with facility management, and there's a scoring system which was also applied, and also a lengthy narrative to also substantiate these scores. So I'm just going to summarize briefly the findings, but I will zoom into newborn care. So to begin with strengths, which is, I think, a good approach always, that compared to previous assessments, progress had been noted in 2023. And also what was acknowledged was good quality of hospital support systems, availability of essential obstetric and neonatal equipment and supplies, and high qualification of medical staff. However, there are several areas for improvement, which includes management of normal labor and delivery. You can see on the slide quite a few items, which is about availability of individual delivery rooms, which is unfortunately not the case in the majority of facilities. Companionship in labor not encouraged or permitted. Birthing positions, monitoring of labor progress, maternal and fetal condition, effective skin-to-skin contact, warm chain. These were all areas that some weaknesses were found in. Diagnosis, management of poor progress of labor, high incidence of C-section, preparedness for emergencies, both obstetric and neonatal, liberal use of formula, quite a few issues. There were also issues found with IPC, infection prevention and control practices, no prescribed algorithms or standards, substandards, sterilization process, substandard hand washing practices, and inadequate monitoring. And a very important area for improvement is also respect for women's rights, their involvement in decision-making, information and communication, counseling, respect for dignity, confidentiality, privacy, avoidance of unnecessary or painful procedures. Also, some system-level issues that were found were lack of national guidelines or protocols, or the fact that many of them were out of date, inadequate system of continuous medical education, and also a substandard information system. So now we'll zoom into newborn care. Okay, sorry, there was a small gap. So when it comes to routine newborn care, already mentioned that the skin-to-skin contact was quite low in 2018, although we have, as UNICEF, been supporting the Ministry of Health to introduce rooming in and revitalize the baby-friendly hospital initiative. However, this assessment found that the skin-to-skin care was done sometimes a bit formally and not necessarily lasting, long enough to really be defined as skin-to-skin contact. Inadequate preparation for resuscitation of a newborn was a major area that we later on worked on with the Ministry of Health, as you will see soon. Also, this assessment found that there were issues, there were a lot of babies with hypothermia, which wasn't addressed and timely or appropriately. The temperature was not checked in all hospitals appropriate for birth. And, this assessment really found that these were areas that really require immediate improvement and that can be improved easily for patient safety. Also, fathers and family members generally were not allowed to visit and support pregnant women during labor or to visit the mother and newborn after birth. Newborns are separated from their mothers after C-section. So even though we supported the ministry to introduce rooming in, when it comes to C-section, that was a bit more challenging. A lot of mothers were under general anesthesia during C-section, and even if not, there was this unnecessary separation. And when you consider that the rates of C-section are quite high in Montenegrin facilities, then you can also imagine that a lot of newborns receive their first feeding with formula rather than breast milk. When it comes to sick newborn care and advanced newborn care, we have this challenge of overcrowded NICU. There's only one neonatal intensive care unit in Montenegro, given the size of the country, and it is really overcrowded, including with recovering newborns who do not need intensive treatment, only close monitoring or additional care. And we found that this was increasing the risk of hospital-acquired infections and also leads to a situation where staff have less time to devote to critically ill newborns. Also, the assessment found that there were no CPAP systems in other maternity units in the country for the treatment of babies with RDS other than in the NICU, which resulted in this over-reliance of the network of health facilities on the NICU. Also, at times, the medication used was found to be not effective or even harmful. Test results, diagnostic, also were found to be at times misinterpreted. Resuscitation protocols or sheets were not filled in, which really made monitoring difficult. The ABGAR score at times did not correspond to the measures taken during resuscitation. Real-time monitoring of sick babies using properly designed monitoring forms was a key area of improvement. And as I said before, also in the NICU and for the treatment of sick and small newborns, extensive use of formula milk for feeding sick newborns, especially in the first days after birth. I would also like to really highlight this area of maternal and mother and newborn rights. So as you can see here, and I already mentioned in previous slides, but I really wanted to highlight that there is this significant issue of restrictions in access and involvement of care of mothers and family members. So as I said before, the relatives are not allowed to visit the woman and newborn during the postpartum period. Companionship in labor is not permitted or promoted, which is also linked to the fact that, as I said before, most facilities do not have individual delivery rooms. But given the small number of deliveries, we think that measures can be taken to improve this situation. Sick newborns are separated from their mothers in most institutions, and there are problems with enabling skin-to-skin contact and early breastfeeding, as also mentioned before. And you can see on the slide here a photo of a mother visiting her child in an incubator, which we really wanted to promote as an example of good practice after we provided training on kangaroo mother care to the NICU. However, I also have to say that the assessors, when they did this assessment in 2023, unfortunately did not witness presence of mothers in the NICU. In general, mothers are so not involved in the care of preterm and sick newborns, and fathers and relatives are not allowed to visit. The assessment also found cases where women with sick or dead babies were placed in the same postpartum group with mothers of healthy newborns. And a charter or a policy that specifies the rights of the mother and of the newborn is not available or developed. And finally, I would like to present briefly what measures were taken after this assessment to improve the situation. And you can see here a timeline that this assessment was conducted in 2023-2024. It was supported by the UNICEF Country Office in Montenegro. It was executed by Horatio Development Foundation and done in collaboration with the Ministry of Health and the Clinical Center of Montenegro. And I'm very happy to say that this assessment and the results that we found really inspired a lot of concrete action. And in 2024-2025, UNICEF, together with the Ministry of Health and in collaboration with LDS Charities, organized various training courses in essential care for small babies, essential care for sick babies, helping babies breathe course, and NRP, neonatal resuscitation, in line with the American Academy of Pediatrics curriculum. Also training in bubble CPAP, because they wanted to equip these facilities, maternity wards, with CPAP systems so that they don't have to rely on the NICU in cases where they can take care of these babies in their own facilities, and this way avoid separating mothers and families from their babies and avoid overcrowding the NICU so that there's consequences of risk of hospital-acquired infections and overburdening staff in the NICU with babies who do not necessarily need that level of care. Also, these facilities received equipment, including CPAP systems. We provided cascade training and supervision, and we are finalizing clinical guidelines in the area of newborn care. And this year, we have been focusing on improvement in maternal care with training in essential care, labor and birth, and preeclampsia. Again, in collaboration with LDS Charities using the JPALGO curriculum. And we are planning now further cascade training, supervision, clinical guidelines, and planning other courses, both in the area of newborn and maternal care in 2026. I really want to thank you for this opportunity to present Montenegro's case study, and I'm definitely open to questions at the end of this webinar. Thank you.
Thank you very much, Ida, for sharing this extremely interesting case study, which confirms really that quality and patient safety is a global matter, and there is always an opportunity for improvement. But the presentation also spoke about really very much the findings aligned with what is there in the literature and the areas that were identified as the major sources of harm in this campaign. So healthcare-associated infections, medication errors, diagnostic errors. The most interesting thing for me was how you spoke about the right of mothers to be there with their children, and the fathers as well, respectful care, which a lot of the time is not spoken about. So thank you very much for taking a look at that during your assessment. And thank you for being with us today. So I hand over to Neda, who will introduce our last speaker. Over to you, Neda.
Thank you, Ida. Yeah, last but not least, and I would say, Liane West, thank you so much for accepting to be part of this panel. We all wear different hats, but yours are particularly interesting. One is the Regent's researcher and the director of the Pediatric Innovation Network at the Georgia Institute of Technology, where you act as an innovation catalyst. But then on the other hand, any innovation, unless it is really run by those who will use it or consult them on whether it really provides added value for them, it will not be accepted, or it will not be a good innovation. And therefore, your second hat is also a president of the International Children's Advisory Network, where you, in a non-profit voluntary way, you gather all the members of the youth with the complex and chronic or rare diagnosis to come together and to see what is it for them, how they can improve the quality of their lives for the life to come because they're young. Thank you again for accepting to present your experience, and I think quite links quite well also with the questions we are already receiving. So we will take them at the end of the session. And that is really how we, from your perspective of those dual hats that I explained and many more that you have, what are the partnerships with children and their families and the communities, the lived experiences, and the central role of children, families, caregivers in advancing the quality of care and safe care? If you can share your thoughts on that. Thank you so much. The floor is yours.
Yes. So thanks so much for having me today. I really, really appreciate being included. Yes, I come to you today talking about iCAN, which is the International Children's Advisory Network. But I think it's important to know that when we build pediatric medical devices, in my day job, we make sure that we include the patient and family, because it's really of the utmost importance to make sure that tools that get developed are safe for kids and made for kids specifically. So let's see. So what is iCAN? iCAN is a nonprofit, and our members are kids. So we look at working with youth age roughly 8, sometimes as young as 6 to 18. And we also have their parents as members. And the idea is that for our kids, most of whom have some sort of rare chronic disease, we give them the opportunity to share what it's like to be them living with a condition, a device, or a drug, maybe what it's like to be in a clinical trial. But the idea is for them to have direct interaction with industry, with clinicians, with researchers, with regulators, so that they understand what it's like to be this patient. We have 46 member organizations around the world on 4 different continents. And we have, and we're a dedicated platform for families to give that input and feedback. So we have activities throughout the year, monthly webinar series, curriculum on things like telling your story, understanding clinical trials, understanding the regulatory space, leadership, because we want to raise a generation of kids who are confident and know they can speak up and know that they should be listened to. And we are a partner with the FDA in the United States, which is really exciting. So I spoke there yesterday about patient safety and drug development. And like I said, we are raising the next generation of healthcare professionals. So through our Young Professional Network, that's about half people who come up through our original program and half people who just have an interest in a career in healthcare. We bring those people together so that they can learn from each other, so that the next generation, whether you're a doctor or building devices or creating drugs, or you're an advocate, you know that the patient is really the expert in the center of everything. And I will say all of our programs are free, and our goal is to reach every child everywhere. So looking at some of the things that are that can impact, like, why do people come to iCAN? Why do kids and families participate in iCAN? And some of it is really around the development and testing of drugs and devices, making sure that their experiences are heard. These kids want to help other kids, they'll tell you that. And we hope that we can help create good choices for treatment, and improve the safety of kids when they're being treated at the hospital or at home. So some of the things that our kids express is having better studies for kids will ensure that a research-backed standard of care is established. I think that that is really, really important, and our kids want to understand that things have been created for them and tested with kids to make sure they do work with kids. Parents feel the same way. Again, kids aren't just little adults. And so we really have to look at testing things with them and for them to make sure that everything that gets created is safe for them. And that's from one of our parent chapter leaders, Deb DeSenza, who also runs Preemie World. So what do our kids think about drug development, device development, and making things safe? They want to be directly involved. They want you to talk to them and engage them. They are the ones going through this. And I realize that, you think that even a 6, 7, or 8-year-old can't really be the one who's being talked to. They can, and they will tell you that. Again, they would feel safer if things were developed for them and if things took into account what they think before things were even developed. And then they have a desire that patients are spoken to directly. Like I said, they want that voice in healthcare and they want it throughout the process. So they want to co-create materials and devices and drugs with you. They want to be a part of it from the very beginning. So through iCAN, we do have a seal of approval program so that if you work with our kids, talk to our kids, get their input into whatever you're creating, we have a feedback loop. And so you can come to us, we can help make sure you're asking the right questions, we can help make sure you're asking things in an appropriate manner for younger children and teenagers. They can give feedback on your device or whatever you're creating. And if you make those changes, then we can give you the seal of approval to show that you cared enough to ask kids and make sure that kids were really the priority when you were developing your device or materials, whatever it might be. So again, we work with all sorts of things. It could be educational materials. It could be the importance of the preclinical trials. Before you set up a clinical trial, talk to us about consent, the protocol, make sure that there aren't any showstoppers in the protocol. What could you change to make it better for kids and families to participate in a clinical trial? Do the families know what they're getting into? So all of those things can help you in the long run retain and recruit families. And some of the barriers we see are community distrust for research, accessibility of research, the lack of awareness of the opportunities that are out there, and then also general health literacy. And again, we are trying to address the last one specifically through our curriculum program. So our Young Professional Network wrote a paper for the FDA recently to champion the engagement of young patients in clinical trial design. So again, before you start running the clinical trial, work with our kids to make sure that it's something that works for them. Are you asking them the right questions to begin with? Are you trying to solve a problem that matters to them as a patient? Again, is it understandable by the patient and family so they know what they're getting into? All of these things make a difference. And so what we do is, again, we provide that platform for companies and researchers and clinicians to come to hear directly from our youth about the challenges they face. We want to make sure that you are addressing genuine patient needs, and we think that by doing this, you can improve your retention rates and your enrollment. And the process is ultimately necessary for ensuring the successful advancement of delivery of therapies for our most vulnerable patients. That's really important, and our kids understand that and know that. So another thing our children have done is at our last in-person meeting this summer, our annual conference, during the week, our kids created a position paper on youth partnership in healthcare. And the QR code actually takes you to this document if you'd like to see it. But essentially, it's, again, some of the things that I already talked about, where they want to be really included and they want to not just answer a survey or a questionnaire, but they want to have a conversation with you and they want to tell you their stories and have you really understand what they're talking about. The other thing is they really want to be engaged in such a way that you're not discounting them because they're young. So actually listen to kids, actually bring them into the conversation. And so here's kind of a closing quote from one of our parents. Our children are not damaged goods. To us, they are the best part of ourselves and the hope for a better future for all. Neonates in the NICU are capable of meaningful and productive lives in their honor and her daughter's honor. Let's work together to do better. It really, really makes a difference if we can all come together, professionals and families, to really change healthcare for the future of all kids. So I think that's it. Thank you.
Thank you. Thank you, Leanne. This was really very inspiring, and it's already very encouraging to hear that children are being, in a systematic way, involved in voicing their needs, voicing their interest in improving their lives. Thank you so much for sharing this. We are almost, the hour flew by so quickly. I didn't really notice. It was so interesting, but then we still have to, we would like to hear from the speakers a few questions from the audience. So I give the floor now to Ida to take over the Q&A.
Thanks again, Neda, and thank you to both our speakers for their insightful presentations. And really, Leanne, it was so refreshing to see child engagement in action, really. So thanks for sharing that with us. So we'll move to the Q&A discussion. Please, colleagues, share your questions in the Q&A box. As we collect those questions, I'd like to start by a question to both Ida and Leanne. You've both described important work from your respective angles. So Ida from the policy level and Leanne from the children and family advocacy perspective. So where do you see the most promising opportunities for collaboration between organizations such as UNICEF and WHO and patient advocacy networks like iCAN to create a sustainable change in child healthcare and safety? Let's start with Ida.
Okay, thank you. This is an excellent question. I would like to say that for Montenegro in particular, we have collaborated with civil society organizations who are not patient groups per se, but they have been advocating for patient safety, for maternal and newborn health. There's an organization called Parents in Montenegro, and they ran a campaign on the safety of maternal and newborn care in maternity wards around the time when we did our first assessment. And I think that, that campaign and also our assessment really together created an environment for change, because it was really something that was amplified by media. And also when we did the 2023 assessment, we invited this non-governmental organization to speak with the international assessors, even though this is not in the methodology, but we invited them because they were doing a survey on maternal and newborn health at that time. And it was really interesting when they said that most mothers are satisfied, this is what they answered in their survey, with the quality of care. But then when we asked them specific questions on certain practices, it was clear that a lot of harmful practices were used in the facilities and mothers were just not aware and knowledgeable about their rights. So I think this is really an area where we can really collaborate and work on raising awareness and educating patients about their rights, including parents and mothers. And also we have collaborated with this organization and used their testimonials and stories. I think one of the speakers before mentioned the importance of using these stories. We use them in training, and we even invited sometimes even families, parents to participate in training courses for health workers. And I think this should be done more often. I think it was really rewarding. And we have collaborated with this organization on health seeking and demand generation for health and ECD services, which is really important. So I think there's really a lot of room for collaboration. And I think that together, we can have a stronger voice and improve patient safety in Montenegro and around the world. Thank you.
Absolutely, Ida. Leanne?
Yes. So, I think about this, and really at ICAN, truly, we believe that every child everywhere can benefit from what we do, and that every child everywhere can grow up to be their own advocate and advocate for other children. And so I think the importance of working together is that, our kids, ICAN is international. We have 46 chapters, but I would still say we're relatively small, maybe not as well known as a group like UNICEF or WHO. And so I think that in working with them, we can reach more children, which I think is really paramount to everything. Children all over the world have different experiences, but there is also a common relationship between them when they see each other, when they meet each other. They all know that they've gone through similar things, even if they don't have the exact same condition. And this really brings them together and inspires them and motivates them. And so again, I think just including children from all over and spreading the word is really, really important. And I think things like the position paper that our children wrote about how and when to include them in research and device and drug development, and also the paper that they gave to the FDA on the importance of including children in clinical trials. These are things that should be shared as broadly as possible. And so we are so happy to bring these things that our kids have created to groups like WHO and UNICEF so that they can reach more children and more people working with children, so that everybody really understands that that patient, that family, that caregiver, they're the experts in what's going on.
So true. And really, I think in the area of child engagement, Leanne, we really need to work harder. And it is a bit challenging when it comes to sometimes cultural backgrounds. Have you found any issues with cultural backgrounds when it comes to child engagement?
Definitely, we've seen differences in countries and how children are engaged, but one of the things that I think is one of the best things that we do is once a year, we bring kids from every chapter we have around the world together. And we have groups, in Africa who are not in cities, right? They're in smaller villages and towns, but we have kids from Europe, we have kids from Asia, we have kids from the US, we have kids from rural US versus big city US. And I think that there are cultural differences, but again, the kids all understand each other, and it's kind of this interesting, safe space for them to be exactly who they are and have other people respect who they are and respect their cultural differences, maybe their physical differences, whatever it is, whatever the differences are, the kids overlook it and they come together in ways that are just really, really amazing to see and important to see. So there are cultural differences, but when it comes down to it, we're all people and we all want to be heard and respected and be listened to.
Glad to hear it, really. Thank you very much, Leanne and Ida. I'll hand over to Nida for the rest of the questions now.
Thank you so much, Ida. Yes, I think you can see already in the chat, Antonia posted the LinkedIn post. The reason being, we have so many interesting questions in the chat, but the time ran out and we still have a small bit by Ida to present the call to action. So to inform you on what we should all do in the coming days or months. But even if we had another half an hour, I don't think it would have been enough. So to keep the conversation going, I would like to ask everyone to post their questions in the chat of the LinkedIn post. And I think the speakers also can be flagged. Everyone who you have a specific question to, they will refer back to the chat and we can keep the conversation going. I think it also helps to stay in touch. It helps us to be a nice network. Building on this, so start from this webinar. Let's try to keep in touch and to amalgamate and to amplify as much as we can. Back to Ida. Please, all of you, send your questions to the LinkedIn. Let's continue the conversation there. Ida, back to you.
Thanks a lot, Nida. So as we come to the end of today's webinar, we'd like to leave you all with our final calls to action, which are directed to all of us across our different roles. Safe care for newborns and children begins with the empowered families and communities. And on this day, we call on governments and health systems to embed family and community engagement in policies and strategies. We call on healthcare organizations to partner authentically with patients and families. And we call on academic and research institutions to prioritize studies exploring patient and family experiences so that we can base really our interventions on robust evidence. Next, please, Antonio. To families and caregivers and the communities to advocate actively, share their experiences openly, and take active roles in co-creating safer care. Never, always to not be afraid to speak up at all times. Civil society and patient organizations, we need to build the strong networks of patient safety advocates and champions, to connect with the WHO's Patients for Patient Safety program, and to amplify stories and voices from around the world to sustain the efforts that we have started together. So in the end, tomorrow, as you know, is World Patient Safety Day, and we would, on behalf of WHO, I'd like to invite you all to organize activities to mark the day, to light up a monument in orange, or wear orange, bake an orange cake, some symbol that brings us all together in solidarity. Spread the word on social media, reshare WHO's posts or create your own. Use the hashtag Patient Safety, World Patient Safety Day, and also share your plans. Let us know what you're doing. Share it on the Global Patient Safety Network. If you're not already a member, please request to join. There's a QR code on the slide that's after this one. Please take the time to scan that if you're not already a member. There is also, we have great materials that we've worked on for you to use, and they are in 6 UN languages. So please feel free to use them and to circulate as much as possible. So with that, I come to the end, but before closing, I would like to thank as well my co-moderator, Neda, the speakers, Liane and Ida, and Dr. Neelam. And I'd also like to thank Antonia, our patient safety star in IAPO, Danny Motsi as well for inviting me here today. So final message, please remember, patient safety is not optional. And for our children, it must start from day one, from the very start. We look forward to your celebrations. Bye for now.
Happy World Patient Safety Day. Bye.
Thanks, everyone.
Happy World Patient Safety Day. Bye-bye.